afternoon, good afternoon. Oh, there it is. Good afternoon and welcome to the July 31st meeting of the Columbia Rotary Club. At this time I want to ask Rusty DePass and Audrey Brown to lead us in our national anthem. Thank you, appreciate y'all. And now, Hal Stinson will give our invocation.
Thank you, Kara. Let's pray. Heavenly Father, thank you so much for this wonderful respite from a Columbia summer. And we know your hand is on us all the time, but especially we're thankful today for that. Lord, we pray as we gather that you would just continue to guide and direct our leaders as we start another year and Carrie takes over. Just bless her work, make it manageable, and just keep her and all the board able to do what they need to do. And Lord, help us all to see and how we can help. So just put that into our hearts today, what we might be able to do to continue to promote this Rotary Club in the community and get to know each other better. We need your help sometimes to just find the time to do that. Lord, we thank you for Rotary and all it does. We pray as we think about the subject today and the rancor that goes on in our country. Lord, may the Rotary peace that we feel sometimes when we come in here, or all the time, emanate throughout this country and the world. We might find ways to work together and find ways to relieve people of difficult circumstances and maybe not be quite so strident in our opinions. And Lord, just we are in need of help to do that as well. Please bless us food and our time together. In Christ's name I pray. Amen. Amen.
Thank you, Hal. Appreciate it. I wanted to take just a minute to say thank you to everyone who reached out to me. First off, Lanier Jones, I'm so glad you just walked in here. Bless your heart. Thank you so much for taking over for me last week. I heard that I missed a pretty incredible meeting, and I'm very disappointed that I could not be here, but I appreciate everyone who reached out to me. Your thoughts and prayers were heard and appreciated. So thanks so much. It really meant a lot. If you guys would, if you have a cell phone, if you will please make sure that your ringer is off. But I did want to mention, we encourage you to take pictures, tweet them, Facebook them, do social media while you're in here. Don't text your friend while you're in here, but we would love it. We'd love to see more social media, so feel free to take pictures when things are happening and put it out there in your networks, because that only helps us bring people here to the club. Right now I'm going to call Louis Fawcett up, and he's going to talk about visiting Rotarians and guests.
Good afternoon. It's great to see everyone. I think we have one visiting Rotarian, Emerson Smith, with 5 Points Rotary. Welcome, Emerson. Glad you're here. And if you have a guest today, please stand and introduce them.
I'm pleased to have with me today John. Thank you.
Pleased to have with me today John Pearson, who's the Dean of College Education at USC.
don't know. I do have a guest, Miss Shelley Woodward, if you'll please stand up. Miss Shelley Woodward from Inland Home Mortgage. She's in my chamber, and I brought her down here to see what we're all about, so please welcome her.
Welcome and thank you for being here.
All right, Mason, are you ready?
Yes.
All right, I'm gonna call Mason Hardy up. He's got some health and happiness for you.
You know, I've been in Rotary 15 years, and I've been in this club 10. I don't recall ever doing health and happiness. It was always my dad's shtick. He always knows the latest corny jokes, and plays the ukulele and the banjo, which I do not do. So I'm going to spare you all of the Archie Hardy rendition of health and happiness. But I will pay a little tribute to him at the end. Health and happiness. Amy Beth Franks. It has been recognized as the 2017 Woman of Influence by the Carolina Regional Business Report. Bob Crutchfield came in with an article from the state paper that's very appropriate that wanted to make sure everybody knew. Where's Mark Lett? Is he here today? There's Mark. Mark has been the executive editor of the state newspaper since 1998. And a newspaper man for 50 years. He's only 64 years old, so he's been a newspaper man / boy for a long time. But he is going to retire from the state, so we want to give him and wish him all the best. So as I mentioned, I don't tell too many jokes and whatnot, so I have some interesting facts to share. But one of my interesting facts is actually a little trivia question. Do y'all know who our speaker is next week? Does anybody know? I'll give a hint. You will not need these, and by the way, they work very, very well. You will not need these next week. We're having a professor from the University of South Carolina speak on the eclipse, but you don't want to be late because this presentation is only going to be about 2 minutes and 30 seconds. You will also not need to bring those glasses with you on August 21st, the day of the eclipse, because it will actually start during our meeting. Approximate time of 1:14 will be the entering of the moon in front of the sun. But the actual total eclipse doesn't happen until 2:43. But you do not need those because we are not going to meet on August 21st. So you all have the day off to look at the sun with the approved sunglasses. Okay. All right. I enjoy interesting facts more than jokes. I have a few of them for you. Some are more interesting than the others, especially as a financial advisor and financial planner. Some are more useful. Amazon's Prime Day, just over a week or two ago, brought in over $1 billion this year and grew by more than 60% from the year earlier. By comparison, that's about the GDP of the Caribbean nation of Grenada. In one day, Amazon did that. Before 1800, no country in the world had an average life expectancy at birth beyond 40. Today, there is not a country that does not have a life expectancy. 5% of the U.S. population accounts for nearly half of all the healthcare spending and half of the population. The healthier half accounts for only 3% of the spending. You might hear a little bit more about that in a minute. I don't know. I thought that was interesting. It takes most people about 6 months to recover financially after a vacation. On average, survey respondents spend about 10% of their annual income on their trips. Over the course of a year, Americans eat about 20 billion hot dogs, with more than a third of them consumed between Memorial Day and Labor Day. So now that's my segue into the honor of my dad. What did the Buddhist say to the hot dog vendor? Make me one with everything. How many optometrists does it take to change a light bulb? Is it 1 or 2? 1? More too. Y'all have a great day.
Thank you, Mason. Before we get to our speaker, I have a little bit of housekeeping that I wanted to talk to you guys about. Debbie sent out invoices on Tuesday of last week, and we're sending out our invoices now via email, which might shock some of you who don't check your email on a regular basis, but regardless, don't let those invoices get buried in your inboxes. That happens to me a lot, and so if you will please, if you have not already seen your invoice, if you will please check and make sure that you've got that. We've been working really hard to get our accounts receivables cleared up, and for those of you who've helped us with that, we sure do appreciate it. We have to pay our bills too. Yes?
Yeah, I'm 74 years old. What's an inbox?
I thought somebody might say that. Yeah. If you don't have an inbox, then we can probably help you with that. Okay. Stephen, are you ready? Okay, I'm going to go ahead and call Stephen Creech up here, and he'll introduce our speaker.
Thank you, President Carey. It's my pleasure to introduce Dr. Shawn Stinson to the club today. Shawn serves as Senior Vice President of Managed Care and Population Health at Blue Cross Blue Shield of South Carolina. In 2014, Dr. Stinson came to Blue Cross to serve as our Chief Medical Officer and Vice President of Clinical Innovation. Prior to that, he was the Chief Quality and Patient Safety Officer of Palmetto Health. A native of Greensboro, North Carolina, Dr. Stinson earned his undergraduate degree from the University of North Carolina, Greensboro. He attended medical school at Duke University and completed his internship and residency training at Johns Hopkins Hospital in internal medicine. He began his career as Assistant Chief of the Medical Service at Johns Hopkins Hospital in 1991 and advanced to Assistant Professor of Medicine before coming to the University of South Carolina School of Medicine in 1995. Dr. Stinson serves on the Quality Advisory Council of the South Carolina Hospital Association. He is a fellow in the American College of Physicians and is a board-certified internal medicine physician. Of many notable career highlights, he is a recipient of the Lewis Blackman Award for South Carolina Healthcare Executive, as well as multiple O'Neill Barrett Teaching Excellence Award winner and Faculty Member of the Year Award winner for the USC School of Medicine. Since coming to Blue Cross in 2014, Dr. Stinson has been working on efforts to further the quadruple aim in healthcare, initiatives that improve the quality of care, lower costs, and improve patient and provider satisfaction. Please join me in welcoming Dr. Shawn Stinson.
I'm not much to look at, so I'm going to step down here. I wanted to start off by asking you if you will, to make this interactive. So if you have questions, please don't hold them until the end. Mr. Beaker, I have to ask that you refrain from some comments so you'll understand what I'm talking about, but at the end, I'm bringing you back from retirement because we're going to need that particular job. I switched for one reason. That was any successes that we had in improving quality, whether that's reducing complications from like lung infections or bladder infections or med errors, or having people not be readmitted to the hospital if it was avoidable, resulted in a decrease in reimbursement. That's perverse, don't you think? I mean, that the better that you do, the less you get paid. And so what I put together here today is to talk about how things could look differently. This is not a political talk at all. First of all, I thought it'd be dangerous to do a political talk. But I would make one comment about what's going on in our state and nation, and that's that what's being addressed right now has almost nothing to do with the cost of health care. It's how it's paid for. They're definitely intertwined, and hopefully you'll see what I mean here as we get going. I wanted to start off, though, just an overview by reviewing the strategy of Blue Cross. Because I will tell you, I never worked out in private practice. So my friends who are private doctors, they're self-employed doctors, I never was one of the gang, because I always worked, in an academic setting. And then when I moved over to work in an administrative role at Palmetto Health, I even lost my academic friends. And then, when I moved to the payer side, my family wanted to speak to me, so anybody wants to have one. But I was thrilled, as I'll share with you in just a moment, to see what the strategy was for Blue Cross. And then to spend the majority of our time talking about what does it mean to actually manage the health of the population, and to talk a bit about what CMS is doing to further this. And I may surprise you with some complimentary comments I'm going to make about CMS, and then the role that all of us can play moving forward. So while this may not show up well, depending on where you are out here, the three inner boxes, or not boxes, three inner shapes there were what kind of attracted me when I got out to Blue Cross. And it's the triple aim. If you've heard of the triple aim, it's something Don Berwick said when he was the recess appointment for the head of Health and Human Services under Barack Obama. And he challenged the nation to think about what do we really want from the standpoint of our healthcare system. And what they came up with, what he came up with, and had promoted in his prior job as the head of the Institute for Healthcare Improvement, was what we really ought to be focusing on is how do you improve the health of the population. That's tough because you have to define what that means. How do you improve the person's, the member, the patient's experience of care? And that, by the way, is not talking about are you happy with your health care, but you have access to people who listen to you, are you part of the decision-making process? And then the third part was how do you actually reduce per capita costs? Because it affects all of us, right? Regardless of what business we're in, the rising cost of healthcare is a huge deal. Now, Stephen mentioned the quadruple aim. That's the triple aim. The quadruple aim is something that I'm very sensitive to as an internist and physician. When I go into the doctor's lounge at hospitals, what I hear is not excitement about the profession. And that's a shame, because I think that there are noble professions out there, medicine being one of them. And I hear doctors saying they wouldn't encourage their kids to go into medicine because it's just not joyful to practice anymore. So the fourth aim is to improve provider, doctor, nurse, pharmacist, social worker satisfaction in delivering care to people who need it. So imagine for a moment, and Ms. Breeder, this is where I just would ask you to humor me. Imagine for a moment that you're the CEO of a large healthcare system. And what is your goal today, the way that reimbursement takes place? I'm talking about from a financial standpoint. So not what connections are you making, downtown, what are you doing from an educational standpoint, with the schools and that type of thing, but how do you keep the railroad running, the railroad here being a healthcare system? So in a fee-for-service world, you're trying to balance your needs to fulfill your mission. So most healthcare systems don't just say, I want to do the really lucrative things. They deliver a lot of other care. It doesn't, most places don't make money delivering emergency room care, even though it's really, really expensive. So that's a cost they have to cover somehow. So where do you think, this is the interactive part, where do you think that a hospital CEO or a healthcare system CEO would be focusing their attention on improving their margins so they can do all of the other things that it takes to take care of a population of people? What's that?
Oh, I said paying patients.
Paying patients. So we'd like to have a good patient mix, absolutely.
Doctor's paycheck.
Got to cover the doctor's patient. That's a cost. That's a big cost. But how would you cover that? What kind of doctors would you recruit? Who do you want on your staff? What kind of specialists?
Orthopedics.
Yeah, specifically, what orthopedists would you like to have on your staff? What do you want them to do? You want to do knees and hips and what else?
Shoulders.
Shoulders, spine. You want to replace joints? You want to replace joints and do spines. Now, do you think as a hospital administrator, that's why you spent all that time building up, your system so you could do hips, knees, and spines? No, you did that because, again, that allows you to take care of a lot of people that come through the door. What other specialists might you be recruiting? Heart, so certain hearts, not all hearts. Which ones? Orthopedics, yeah, absolutely. Orthopedics, so like we said, the joints, spines, and some hearts. Not every heart pays. Some of them are too complicated, it doesn't pay. But that's really what you want. Now, you will recruit them even if there are more than enough in your community, because it produces a margin. Again, you've got to cover your margin. So in a moment, I'm going to ask you, all of you are going to be promoted, demoted, however you think of a hospital CEO job, but you're going to be asked to become the CEO of a healthcare system, we're going to give you some size here, of something around $3 billion. That's a pretty big system because you're going to be asked to create the new healthcare system. I'll tell you what that means. First though, I'm going to put up some slides that most of you have seen. And it's going to just kind of beat us up. And then at the end, I'm going to tell you why I don't think we should be beaten up. But here's where we're going. So despite relatively slow growth of healthcare, all of you know, we're now north of $3 trillion being spent. Over $10,000 a person, 18% of our GDP, more than 18%. We're going to be at 20 not too long. And what does that mean? We actually spend more on healthcare than the entire GDP of all but the 4 largest countries in the world. Not what they spend on healthcare, their entire GDP. So despite what you hear, and what you might hear from a primary care doctor who you know, to say we should be paid for stuff like that, despite what you hear, there's more than enough money to go around in healthcare. You can come back later and challenge me on it, but I'm going to try and make a case for you. So healthcare inflation outpaces CPI, Consumer Price Index, right? You've seen this in your businesses. Your costs for premiums or just total healthcare costs are going up. We saw a little bit of a slow a few years ago, thought maybe things were going to turn, but they didn't. They're starting to go back up. We spend 2.5 times the average of the OECD. OECD, the Organization of Economic Cooperation and Development. These are the 34 most developed countries in the world that work together in partnership to improve social aspects of their systems as well as healthcare. Now, it's not important that you see the absolute numbers, but let me point out a couple of things here. Just so you can see the bars. So this is us, United States. By the way, this has been 2012. At that time, we were at $8,000 per person. The light blue bar at the top, that's private expenditure on health. Down below, the darker blue is public expenditure. This line right here, this color, that's the average for these 34 most developed countries. And you can see where we stand compared to average. You can also see where we are compared to Norway. We're at the top. So one of the questions that you get, and you certainly hear it when people are campaigning on both sides, is do we get our money's worth? Well, this is life expectancy. Again, it's not important you can read the slides, just let me point out a couple of things. The red, that's OECD average, United States, green. So we spend a lot of money, but we don't live longer, right? And very often that's used as a judgment on the healthcare system of the United States. Obviously it doesn't work because we don't live as long, we could spend a whole lot more money taking care of folks.
Is that by number or percentage?
This is what are you asking?
Well, I mean, there are 300 million people in the United States, so they only be 20 million or nothing. So I can compare this.
Okay, perfect. So it's of people that were, it's the average lifespan of that population. But thank you.
One other question, where is Australia and Canada like?
Okay, so let me point out a couple of places on here, thanks. So Canada is here, lifespan 81. Australia, 82. Switzerland, 82.8. By the way, we're better than Chile, Czech Republic, Poland, Estonia. So is this a fair judgment on the healthcare system? Well, one of the things, if you read much about the determinants of health, then you'll recognize that the social determinants play a much larger role. So the stuff that happens in a healthcare system influences health, but only about 10 or 20%, depending on what you read, of the health is influenced by what happens in a traditional healthcare system. Yes, sir?
Some of this is a little bit of a straw man, isn't it? Because, I mean, there are a lot of demographic differences, population controls, so it's a little bit of a straw man.
You're setting it up beautifully, because I'm going to come back and try and, I probably won't say it as well as you did, but I'm going to try and make the same argument here. So medical care, health behaviors, genes and biology, social characteristics. Okay, so a lot of by the way, the money that we're talking about spending is almost all here. Now, one place you could have gone with that is those other countries, while they may spend a lot less here, they may spend a whole lot more over here, right? So there may be, those dollars may not quite add up, but depending on where you are in a campaign, you might beat that horse as much as you want to. So let's back up. Death from all causes. First of all, everybody dies, right? So we've had a couple of documented no deaths, but other than that, this is age-adjusted deaths. Now, we've changed here 12 most developed countries in the world, and this is the United States, and you can see that deaths from all causes of these. We're not in a good position here. Violence, there we are. By the way, this does not have Syria or Iraq. These are the most developed countries in the world. So, but in places that, you know, we would probably all enjoy visiting, violence. Road traffic accidents. And for those of you who've had the pleasure of going to Italy and Germany, oh my goodness, I can't imagine, but we lead the pack there too. Maternal conditions related to pregnancy. I mean, this is a travesty, right? I mean, why in the world would we be so far behind on that? So the bottom line here, depending on how you look at it, I mean, it's from just pure dollars and how long you live, that's going to be your judgment. The United States spends a whole lot of money, and we don't live as long, particularly for that amount of money. Now, this slide is not intended for you to read. This has all those things together, all the social determinants of health, all the different partnerships you could have. If you wanted to fix it in population health, these are some of the things that you'd be working on. We're going to dive in a little bit more. But keep in mind the quote, every system is perfectly designed to, oops, there's an extra word there, to achieve the exact results that it gets. We are perfectly designed to spend a lot of money and to not live as long. It's at the healthcare system's fault. So we've got to ask the question, what do you want? What do you want from a healthcare system? So if you want the best sick care in the world, you can go to almost any hospital in the United States and you will be able to take advantage of technology that is not available in almost every other country in the world. You don't want to be any place else in the world and have a child born with severe congenital anomalies. The United States is where you like to be born. You don't want a child with severe congenital anomalies, but if that happens to you, if you have a severe trauma, maybe Israel, but probably here would be the place that you want to be. And advanced cancer, this is where you'd want to be. We have, even with all the things that you read which are true about how dangerous the health system is, you know, with complications and things like that, we have the best sick care system in the world. That's what we're designed to do. We're designed to take care of desperately ill people. And like I said, even with the complications that we have, we're extraordinary at that. Is that what a healthcare system should be designed to do? That's the conversation that right now, I think, is being had. It's not being had very clearly, though, and it's certainly not being articulated by people who can drive large national conversations. But in my current job, I get to go to a lot of employers to talk about their healthcare coverage. They definitely focus on sick care. You know why? Because they want to know why they have such high cost claimants. But their job, what they see that we, payers, providers together, and others should be able to do is to keep their folks healthy and at work, right? So, quick definition, we're going to talk about population health. The population is simply the total of individuals occupying an area or making up a whole. This is the population, the Rotary Club. By the way, thank you very much for what you do for the community. This is the population. Your neighborhood's a population, your employer's a population, your state's a population. You can define it any number of ways. Population health, the health outcomes of that group of individuals, including that distribution of health outcomes. The distribution is a really important part here. Population health management is how do you coordinate the care delivery across that population so that you actually achieve improved health. So, now you're all CEOs of a $3 billion healthcare system. And rather than worrying about fee-for-service, you no longer have to cover the margin. Because what just happens, we just fast forward, maybe it'll happen, maybe it won't, I believe it will. We fast forward to some kind of system where you now get that $3 billion plus some. Here's $3.3 billion. And your job now is not to manage who comes through your door. Your job is now to manage a population. So if you're in this area, we pull Mr. Beaver out of retirement, I promise you, sir, you don't have to say a single thing. But if we pulled you out of retirement, we'd say, here's $3.3 billion, we want you to manage Lexington County, half of Richland County, all the political stuff aside. Lexington, half of Richland County, and maybe part of Fairfield, something like that. You've got 400,000 people now that you have to manage. You've got $3.3 billion to do it. Yes, sir.
The demand for doctors is booming. Loads of young, very smart kids want to get into med school and don't. Are the medical school and nursing schools expanding? Are they creating more doctors and nurses in South Carolina?
So nursing schools have expanded. The medical schools have expanded in this state considerably over the last 4 years. The residency slots have only increased marginally. So we're producing a lot of people that are graduating with MDs and DOs, but they're not doing their residency training here because we didn't expand that. Completely separate, I mean, that's an important piece of this, but a completely separate part of the argument. Nurse practitioners expanding, physicians assistants expanding, RNs expanding.
Would that, more doctors increase the competition and help lower medical costs?
Okay, so now you're the CEO, you've got $3.3 billion, and you've got to manage 400,000 people. Some of them are healthy and well, they're 18 years old, not a care in the world. Some of them are 75, they've got congestive heart failure, they've been in the hospital 3 times. What, are you out recruiting orthopedic surgeons and cardiologists? We're going to get to your question.
Prevention.
So you said prevention, what?
I look at how I can integrate prevention into my healthcare system, because we can prevent these serious illnesses and diseases. That saves us money in the long run. We have a healthier population.
Okay, so today, by the way, no villains here. So no, the providers aren't bad, payers, just humor, payers aren't bad, providers aren't bad, employers aren't bad, population's not bad, no villains here. Today, how much money do you think we pay for prevention? Yeah, it's not sexy at all. Paying for prevention is not sexy at all. We pay a ton for really, really tough stuff, good outcomes or not, we just pay a ton. We're not paying to keep people healthy. But when you say that, that's complicated. What does prevention mean? Who are you talking about? Who do you now go out and hire?
You know, I think that having diverse, I have to think diverse. I need community health workers, people out in the community, on preventive health. Gosh.
What about the interns?
I mean, you know, yeah.
Okay, so primary care, you're even before primary care though. You're saying if you're going to hire doctors, you're going to hire primary care physicians, you're going to be out in the community where people actually live.
Right, or in school, health nurses.
In the school system. Yep.
You know, dental, I mean,
Yep.
again, that's what I think I should do first.
Well, I want to hear all of them, yes.
The things that I keep reading is where we miss it in America is our food is unhealthy. The populations that stay healthier longer are not eating as much animal protein. They're eating more fruits and vegetables. They're having more balanced diet. They're getting the exercise. And we do not do that. So, and we look at our restaurants, we look at the menus. They're not.
You just expanded it, so you just stepped out of healthcare, right? But what you're acknowledging is that there's a lot to
But
this.
there is some help there in that.
Absolutely.
Much further.
So you got, as the CEO of this system, you've got to think far more broadly. I was in a meeting, there's an organization in town, Healthy Columbia, have you heard of that? It uses principles of organizing like was done for political campaigns, Tea Party, Obama's campaign, but it's applied at the community level to improve health. They were in 29203 is where they started, and they've expanded from there. 29203, the largest number of amputations in the nation due to diabetes. Oh my gosh, right here in Columbia, South Carolina. So we're having all these town hall, house meetings and town hall meetings, and I'm sitting at a table with people from the community, other doctors and business leaders, and we're talking about why do we not eat more healthy? And you know, I come from a privileged background, and I'm sitting here with a woman who's single, works, has insurance, and she said, Dr. Stinson, how much does a bag of apples cost? I have to tell you, you can judge me if you want. I don't have a clue. I know now. I didn't have a clue. And I said, and I didn't know where she was going, although I could feel it wasn't going in my direction. And she said about $5. I asked my wife later, and she said, well, it depends on the size, but now if you go to the grocery store, almost all bags of apples cost right at $5. There's a reason for that. So I said, so help me. And she goes, I've got 2 kids. We can eat healthy. I can take them home, $5. I can feed them a bag of apples. Or I can take them to McDonald's. We can go to the value meal and they'll go to bed with a full belly. That's the reality that she lives with. So as the CEO of that system, it's not just to get out and educate folks, right? It's to figure out how we have things that are, as you were saying, convenient, but also can they can afford. Yes, sir.
One of your competitors is incentivizing their population by giving them reductions in their deductibles and co-insurance for the distance they walk, or eating healthy, for these kinds of things that can be measurable. I don't see Blue Cross doing that, but bottom line is those are ways to incentivize them financially.
God, it just got personal. So in reality, I mean, I think it's a really fair statement. And in some populations, we are doing that. Are we doing that across the board? That's one of the things we're working with on employers. I don't want this to be a commercial, but you are so right. That focus needs to be back downstream. But hey, him, what else would you want? Who else would you be out there trying to get as part of your system? Yes, sir.
Not exactly with your question, I guess I'm your foil to that.
Bring it.
What you're saying sounds very much no longer medical care, but sounds like social health care. So if I give Mike Beaver charge of Lexington County's health, then and you start talking about menus and prices of apples, then we start talking about, well, we got the lower price. I mean, here's how we get into socialized medicine. I think part of the polarization in the country today is there really is a difference of opinion on what we want our insurance companies and doctors doing. And it sounds like insurance companies are sort of getting on the bandwagon of the socializing, as long as there's a role for them.
Yeah, let me dispel you of that notion. So I should have started off. I'm not speaking for Blue Cross Blue Shield. They're very aware of what I'm saying, but that we're in a process. So great points. As the CEO, as each of you are the CEO, you've got $3.3 billion. You're not going to be able to go out and re-engineer the social system of your community. What hopefully you can do, though, is to start influencing in ways that you've never thought of before. And as employers, you need to be thinking of how you can influence it in ways that you've never thought of before. Don't think of this as that $3.3 billion is going to allow you, hopefully, to hire some additional folks to work in communities. But let's face it, you still got people in intensive care units. You've got joints that needs to be replaced. You've got hearts that have to be fixed. You've got to have, your job just got far more complicated. It didn't get any simpler. What else would you want to have, though? Yes?
Well, I'll just point out, too, you're talking about all that money going to managed care, but everybody's terrified of going to the hospital for staph infections, other infections, protective viruses that are coming out. It doesn't sound like
Put skin in the game. Put skin in the game. Okay, so right now, probably all of you are aware, if you have, and I'm sure, because as a quality officer, I promise you, I knew every one of those infections that we had. There's a penalty for them. Here's the thing, though. That penalty doesn't add up to the revenue loss that you have from preventing. Does that make sense? Okay, so you're going to get penalized by CMS. By the way, you'll get penalized by Blue Cross. We've got a reward next. Ours is you'll get a withholding benefit, not a penalty. So it's your rate increase that for the same amount. So if you prevent readmissions, take that one. You'll get a significant penalty from CMS for having too many readmissions. If you pay to put a team in place to prevent those readmissions and all the hard work that takes, that's a cost. You're losing revenue because those readmissions also pay. So far, the benefit is still in your favor. So far, it's getting ready to change. It's in your favor to keep doing business as usual. But I promise you, every hospital in the state is focused on readmissions and they're working hard. But right now, it's really a difficult conversation with the CFOs. So we're rewarding still, it's getting smaller, but we're still rewarding performance that's not quite where you want it to be. And you would never want it to be there as a patient. Yes, sir.
Are there businesses or industry groups that would model prevention piece to this that you're talking about? And I'm thinking about electric utilities, for example. They have critical safety needs that serious. They have ongoing safety training, not only for their linemen that are working out in hazardous environments, but every employee gets how to drive an automobile safely, how to park. Do they have better health outcomes? Or are there any models that the rest of society can have?
So I don't have data on all the co-ops, but we do work with some. And by the nature of the job that they have and the employees that they actually don't have reduced healthcare costs, but thank God for the programs that they have. Does that help? No? I mean, what would it be if they didn't have that focus on safety and improving health? So I'm gonna cut to the chase here with a couple of other things. You guys have hit almost all, but one thing that's really important is data. So how do you know who you got to manage? How do you know who you're going to put a case manager on, or a disease manager, or where are you going to send those community health workers? So one more hand up here.
Yeah, I had a question. Of the $1+ trillion of health costs, how does that break down between employee costs for treating the people, brick and mortar, health insurance costs? You know, where can we say have the most savings from that standpoint?
I don't think I can answer, and not because I don't want to. I don't think I have the knowledge to answer that question. I can give you just, this doesn't get it, but let me give you one concrete fact. So of every dollar we pay out, Blue Cross Blue Shield pays out, 16 cents goes to musculoskeletal. That's an amazing thing, isn't it? 16, 1-6, not 60, but 1-6.
Goes to what?
Musculoskeletal. It goes to fix knees, hips, spines. It also, that includes rheumatoid arthritis, the inflammatory joints. 16%. And as we go, like I said, I go to a lot of employers to talk about their costs and what we can do. And it almost doesn't matter what industry we're in. I mean, that's an amazing thing.
I guess my biggest question is, are we going to end up with socialized medicine?
I don't think we have. I don't think we have to, but I think we have to do something different. Is the point. So if we don't do, and by the way, it's not you as the CEO of the system. It's you as the business community. It's you as the population. If we don't have some different conversations, we could easily end up in that direction. So what I'm hearing: shift care from emergent to preventive. Thank you very much. Provide care in the most effective and lowest cost setting. That could be in the home or nursing home, or in the employer's site itself, or in the school. Break the reliance on perverse incentive. Manage the care of those who need it. Utilize big data. How do you utilize big data? So every payer in the country and almost every healthcare system now stratifies patients. They say these are our high-cost patients, rising risk, at risk, and healthy folks. The highest cost at the top. You've heard the data that 5% of the population accounts for about 60% of the costs. Wow. So that you can't fix that in the community because we still have sick folks. We need to have very aggressive case management, care management, put people where they need to be to get the best care they can possibly get once they end up there. But listen here, this group right here, the rising risk folks, some of those are going to be in high cost, and some of those are absolutely predictable. So one of the things that we're working on, we're not unique, other payers are working with us too, other healthcare systems are working with us too. If you're that CEO, you'd be investing in this. Identify those people in your population that next year are going to end up in the hospital with that heart attack, or you can name it. The best systems in the country are able to identify those people that are going to go up there and prevent half of them from going up. And they do that by not focusing on fixing something once it's happened. It's getting out and managing it. So we've got a model. We're just getting ready to put it out. Of people that have diabetes, we can now predict who is likely to get admitted next year with a complication of diabetes. This isn't science fiction anymore. So now it would be now working with them, because they don't want to get admitted with complications of diabetes. They know they have it, but we might have gotten their attention before. They might have had their attention before, but now it's getting ready to get really good for them. Recognize the roles of education, business, government. So when you're saying, are we headed towards socialized medicine, or where should we focus our attention? So as that CEO, you've got to create this system You've got to work with your teams to create this system. But now your partners are not just case managers, healthcare workers, doctors. Now your partners, that is the school system. You don't have to run it. Your partners are now the legislators downtown. Your partners now is every business in that community. You need to be reaching out to them. I act like I know what I'm talking about. I don't. This is made up.
You've just touched on, I'm with SC Economics, and we help with, we're in the educational space, and we are beginning to put more and more emphasis on the healthcare insurance piece, because that's part of financial literacy. It also is thoroughly ingrained in economics. So, but it's a murky field, because you're trying to find facts versus quarter facts, half facts, etc. Where would you, and somewhere as you go along with all this, could you maybe articulate where you consider to be good resources of factual information for people trying to understand and educate?
I'll do my best.
You just put education up there, because I consider that a very big piece of your solution.
Yeah, so I'm going to try. You can tell me at the end if I get touched on it. I'll touch on it. I don't know if I'll get it in a great place where you want it to be. Align incentives. Again, as I talk, I've taken care of patients for 20 practice for over 20 years. That doesn't mean I know what patients want, but I have a pretty good feel. I mean, they want to be heard, they want to be managed well, they want the quality care. If you talk to providers, doctors, nurses, they went to school to deliver quality care, to earn a good living. Employers, they want great care. They want their employees to have access. They want their costs to be controlled. They want people to get sick, they're made well, they come back and they're able to work. Payers, we're in that quadruple lane. That wasn't made up. That's what payers want. They want people to get great care and to the health to improve and to control costs. So are things really going to change? So this is a slide that most healthcare providers know very well. We live up here in a fee-for-service world right now, which means somebody submits a claim, somebody gives them a check, right? And that's how fee-for-service works. There's contractual stuff, but that's basically how that works. Fee-for-value, defined in any number of ways, but somehow you're getting paid for adding value. Value, loosely, not well defined as quality over cost. So we're someplace in here now. Fee-for-value, I'm going to show you some numbers. Fee-for-value is increasing. Fee-for-service still driving railroad here, but at some point it's going to cross over. And you, as the CEO, have to be prepared for that crossover. I'm arguing I think you can drive that crossover by making us align. So it sounds simple, it's not. Here's the path toward accountability. Fee-for-service over here, full out, full risk, capitation, the old HMO stuff where it's just based on resource utilization back in the 80s and early 90s, which didn't work, right? I mean, it worked in some geographic areas, but I think it's because they were ahead of the game. They were absolutely focused on resources, but they also focused on outcomes. And I think that's what makes us different this time around, is that we've learned a lesson. This is not about just resource control. This is listening to your population and providing what they really want and need. So CMS, this is really important just to get to the next slide. Category 1, plain old fee for service. Category 2, some aspect of your payment is linked to quality or some kind of outcomes. Category 3, now there's some payment for population health management, but you're still on a fee for service chassis. And Category 4 is it's what we were talking about. You've got a population of people managing. So how is CMS doing? Because they're driving this thing. Catherine Sebelius, former secretary, said, and she said this in 15, she said by 16, 30% of folks are going to be in Category 3 and 4, and 85% in Category 2. And most of us went, that's just absolutely crazy. At 16, they passed that. 18, half of what they pay out is going to be an alternative payment model. They're not there yet. And 90% linked to quality. So again, when they came out with their rules, and I know at Lexington had the same thing, when they came out with the rules 2 years in advance or 3 to 2.5 years in advance, they said, here's where your penalties are going to be. They had teams, we had teams working on it. That's very different trying to avoid a penalty than doing a transition to population health. But it now gets people thinking of, what does it take to keep people healthy out of the hospital, not in their clinic? So where is Blue Cross in this mix? Again, not an advertisement, but just so you know, right now, we're between 14 and 18, and we're at about 60% of the dollars that we pay out are somehow related to quality. So when a hospital comes to us and says it's time for our contract negotiation, the first thing we do is pull out the quality scores. We send it out 3 years in advance. They know exactly what we're working on. That's where the conversation starts. Is how'd you do? And if they did really well, then the conversation ends there because they're happy, they got a big increase. The conversation doesn't go well because the quality wasn't there, there's still a negotiation. Sometimes it's not friendly. It's getting friendlier because we're becoming more objective. You don't argue with CMS, right? But there's the private and government's very, very different. The red up here, you can see we're very small. What the red is, that's category 3 and 4. So that's where you're really taking out the sole reliance on fee-for-service and now paying for other things, like care management, for example. Some of the payment innovations. So last thing for the summary slide. So today in our state, we have a number of organizations, healthcare providers, who have put a flag in the ground and they said, we're going to manage a population. And we're going to invest in data. We're going to invest in community health workers, doing some really cool stuff using paramedics. We're going to invest in more primary care. We're going to continue to operate high-quality ICUs and surgery suites and that type of thing. But we're going to be ready to manage a population. And now several of them have actually gone beyond that and said, they've all managed their own populations, their own employees, or most of them have. And now we've got some that raised their hand and said, we want to manage Medicaid patients. Give us several counties. We'll go at risk. If you want to see a system make a transition, do what we just talked about today, put them at risk. Because now this conversation about risk, what I mean is that there's a certain amount of premium coming in for a Medicaid patient. It goes to the MCOs, the Medicaid Care Organization. Those are the private payers that manage that. The private payers now have relationships with a variety of hospitals. They said, if you manage county X and Y, we're going to give you that premium. Minus our administrative costs. And that's a whole different conversation. But now what the hospital, what those health systems are doing is like not trying to drive to who can get the most people in for a hip or knee replacement, right? They're trying to drive to how can we keep people healthy and out of the hospital. This has started. That's a really cool thing. This has started. We've got a variety of different payment innovations that are underway. Primary care, 4% of every dollar we pay out goes to a primary care doctor. The primary care doctor, by the power of the pen or the computer, depending on what system they're using, controls in some way or influences 85% of the dollars spent. Who do they refer to? What do they order? What tests do they order? That type of thing. So one of our programs is the Patient-Centered Medical Home. Patient-Centered Medical Home provides care coordination fees. Our next iteration, which is coming out later this year, is where we actually take into account that 85% and start sharing that with primary care providers, and they're able to do a better job in controlling the cost. And they don't get a penny for controlling the cost unless they hit the quality outcomes. That's the difference from the 80s. So that's your ticket to the game is good quality. And then resource utilization is how you get the biggest benefit. That doesn't address what you were saying. That's the direction we're headed. We've got the data on how that's working in certain areas. Happy to sit down with you if you want to talk about that. So in summary, this move toward population health management is at the forefront of CMS. And by the way, Secretary Price is absolutely in favor of innovation. CMMI, the innovation arm of CMS, he is a big supporter of that. Well, he's not a big supporter. You've heard it if you've listened to it. It might not mean anything when you hear him talking. He's not in favor of mandates. So telling a doctor that you have to participate in a bundle for hips and knees, which Florence is one of the areas chosen, 75 areas in the country chosen where it didn't matter if the doctor wanted to do it or not, the health system wanted to, you had to go into a bundle payment arrangement. which means you're gonna get X number of dollars, no matter how sick the patient is or how they do or whatever, you just gotta manage it. He said, he didn't want that, didn't feel like we were ready for that. But as far as continuing to move down fee for value, absolutely a supporter. We'll see. CMS has announced their goals, we just talked about those. We need to continue to refine our place, talk about Blue Crosses, we need to continue to refine our place, your place, in this healthcare market, and to recognize that it's not the 10 to 20% that's truly gonna drive it. I'm not talking about socialized medicine, I'm not. I'm just recognizing that we can only affect about that much if we don't also address those needs. But go ahead, this is dangerous, but I'm just going to hit, because you can tell by the way I talk, I'm a social liberal and a fiscal conservative, which means I'm angry all the time. There's nothing you can do that makes me happy. Yes, ma'am.
For the last 10 years, our national politicians have been discussing healthcare. But it seems like all they're discussing is how we pay for healthcare, not the cost of healthcare. There is I see no innovation in anything that's going on in Washington about dealing with the cost of healthcare.
I 100% agree. Little dances around drugs and stuff like that, but it doesn't get to the root of the issue. And I firmly believe that, and by the way, Stephen's a big push behind this talk. I firmly believe that what we're talking about today, and I'm biased because I put it together, but I think this is at least part of where we should be heading.
Yeah, but there's no people who are really going to make
That's
what
insurance.
we're talking about.
No, that's insurance. And how do you
No,
get
I
paid?
want about insurance. And the insurance isn't going to get any better as long as the cost keeps going, right?
Yes.
One of the biggest, in my opinion, one of the biggest cost drivers compared to like 60 years ago in medical field is technology. Technology is great, it prolongs our lives, but it's jacking the cost up. 50, 60 years ago, you getting hip replacements or thing like that were archaic, nobody knew about it.
So every system is perfectly designed to get the results that it gets.
So why don't hospitals, if you're a large driver of this, why don't hospitals consolidate such that the area, if you need an MRI, you go to this hospital, you need something else. Why does everybody have to?
I'm not going to deal with that.
No,
Let me say, okay, so no,
I'm
fairness.
going to try to cut costs.
Okay, but think of your costs are the revenue that's necessary to do all the social things that Mike did for the county. Again, no villains here. So let's take, just as I can finish up, can I have just a moment, just quickly? Yeah, 1 minute. So today, in this community, we have 1 minute. With this community, you can go get a hip or a knee replaced and go home that evening. Midland's Orthopedic. Now, if you're, and I'll speak for the organization where I told you, had this conversation not come up, I would have been very happy to retire from there. If you're looking at that, do you look at that in a friendly way? No, you don't look at that in a friendly way. Why? Because, again, we acknowledge right up front, those joints, that's a big part of your margin. That allows you to have emergency medicine, behavioral health care, and all that type of thing. If you're a patient, do you look at that favorably? Absolutely. After the first, and they're happy for me to say this, after the first 500 joints that they replaced at Midland's Orthopedics, how many people do you think got admitted to a hospital? By the way, when I was in residency, a hip replacement was a 5 to 7 day hospitalization. So 500 people had a hip and or knee replaced. How many people got admitted to the hospital? 1. How many joint infections? Not one's deep one, 2 superficial joint infections. So last year, we started, the other orthopedics across the state started doing it. Right at the same number, a little over 500 joints replaced in the state last year in an ambulatory setting. Again, 1 admission. Now, if you're a hospital executive, and I was an administrator there, you'd say, well, they're cherry picking. And the answer is absolutely. They're picking healthy people that need a joint replaced, by the way. They're not replacing joints that don't need replaced. But healthy people, but if you don't have that resource in your community, where do those healthy people go? To a high-cost system. Now, that's not the hospital's fault, I can promise you. We've got to work this out from a payment standpoint, because that's revenue that a hospital needs, again, to fulfill their mission. But overall, if you start now to take the whole risk of the population, the conversation changes completely.
In lieu of time, we're gonna forego songs, so thank you all for being here. We appreciate you, Dr. Stinson. And next week we have our Eclipse program, so please come back next week so that we can talk about the Eclipse. All right, thank you.